Are you ready to advance your career in one of the most dynamic and impactful fields in healthcare? Welcome to the Cardiac Critical Care Fellowship, an entirely online program designed to fit your busy schedule, offering 3 comprehensive modules, each worth 30 credits. Learn from world-class clinicians and gain access to evidence-based content, cutting-edge research, and real-world case discussions in cardiac critical care. This program is tailored for self-driven learners who want to take control of their education and unlock their potential. Whether you're managing critically ill cardiac patients or looking to master ECMO, mechanical circulatory support, or perioperative care, this fellowship will empower you to excel. With flexible, interactive, case-based learning, you'll gain the skills needed to advance in this high-stakes field, all while earning certification to boost your career. Join us today and start your journey towards becoming a leader in cardiac critical care. Are you ready to make a difference?
Hi everyone, good evening. This is Abdurrahman Asiri, and a very warm welcome to all of you joining us today. It's truly a pleasure to host you this important session as a part of our ongoing educational series. First of all, I would like to extend my heartfelt appreciation and gratitude to our distinguished speaker, Dr. Muhammad and Dr. Ismail, for taking this time from their busy schedule to be with us and share their expertise. Also, I would like to thank our moderator, Dr. Bashir, for her effort to guiding today's discussion and ensuring that will be session run smoothly and prospectively. So before we begin, just a few quick note and announcement. This session will be being recorded, and the full recording will be available later in our official YouTube channel for those who want to revisit and the discussion or share it with a colleague. Also, please feel free to post your question and answer in any time during the presentation in the box of the questioning box. Thank you again. Dr. Bashir, the floor is yours.
Perfect. Thank you, Dr. Abdurrahman. So good evening, everyone. I'm Dr. Bashir. I'm a consultant cardiologist in HealthPoint Abu Dhabi, and it's my pleasure to be moderating this webinar this evening. Because of some important patient care, Dr. Ismail can't be here, so we'll start with our second session. And I have the pleasure of introducing Dr. Mohammed Al-Mahmadi, who is the director of the Cath Lab and program director of interventional cardiology at King Fahd Medical City. And his subject is titled Left Heart Cath Triggers When to Push the Button After Surgery. So the floor is yours, Dr. Mohammed.
Thank you so much. You hear me well, right? Okay. So I'm gonna share my screen here. You guys hear me very well, right?
I can hear you clearly, yes.
Excellent. So basically, this topic is a very dynamic topic in terms of what to do. I mean, if you are in the ICU or cardiovascular ICU, you always face hemodynamic instability. And one of the most challenging things, especially in cardiac patient, is when to pull the trigger and activate the cath lab. And we face that, I wouldn't say on a daily basis, but at least once or twice a week, where a patient or a colleague from the cardiovascular ICU asked us to consider doing a cath for these patients. Why this topic is important? Because it's kind of challenging decision to make. There is a risk behind doing cath in these patients, because most of the time you're going to utilize blood thinners, either IV heparin or any, or if you do a PCI, you might place the patient in a dual antiplatelets while they have like a fresh wounds or something like that. So it is an important decision to make. The topic was initially about left heart cath in general, but it sounds like it was limited to left heart cath post cardiac surgery. We can talk about left heart cath in detail in a different session. With that being said, I want you to put your questions because you cannot cover this topic overall. I put just the point that you need to learn for your daily practice. So it's more of a practical talk and should be dynamic talk than a topic by itself. So the objectives we're going to have here is to identify the post-op warning signs, some sort of a rapid decision algorithm, and when immediate cath is life-saving. And I think that's important for you to know. So what are the immediate cath triggers? And that should take priority when you see these signs. If you see a new ST elevations, usually ST elevations do not lie, especially if it's consistent with hemodynamic instability. If you find any post-cardiac surgery with unexplained hypotension, unresponsive to pressors as well. One of the measures, the objective measures that I usually tend to rely on, and that usually this marker never and almost never lies, which is the lactate. We can argue all day about hemodynamics. We can argue about the wedge pressure, the RV pressures, the PAPI, the cardiac power output. But the lactate usually is a very consistent factor if the patients are not perfusing very well, as well as the mixed venous sat. The regional wall abnormalities, especially the new ones post-op, also can be a major player in this area. So you want to base your decision on a flow chart, and I'm going to show you a flow chart that we developed as a center locally in our cardiovascular ICU. But you always start with if there is hemodynamic instability. If there is none, then you should just continue monitoring with either echo or labs. If there is hemodynamic instability, the most important things to rule out in post-cardiac surgery patients would be tamponade and RV failure. And as we pointed early, using IV heparin and other antiplatelets or anticoagulations, if a patient is tamponade and you just blast them with blood thinners, you're going to make the problem worse. So in these cases, you really have to be careful. RV failure is a completely different animal, and dealing with or getting distracted with left heart cath while the patient is having RV failure can actually be a fatal mistake. LV ischemia, if it's suspected, just immediately ask for the cath. If it's unclear, then you always never go wrong with doing an echo, either bedside, but if the patient is vented, lying flat, you cannot really get good images by the transthoracic, then T is your guy. And if there is any concern, then you should activate your cath. So another way to ask this question is when not to cath first. And as we mentioned, if you suspected tamponade, then this patient has to be reopened because in post-cardiac surgery patient, the tamponade or the effusion usually don't tend to accumulate anteriorly or apically where we can reach it percutaneously. It usually accumulate posteriorly, and that's usually very challenging, if in some cases impossible to reach it by a needle, and the patient has to go back to the OR and be reopened again. If there is a massive bleed, then that's not the time to think about cath. If there is pure RV failure sign, and we're going to talk about some of them, and if there is vasoplasia shock, especially in patients who you just place the ECMO, or sometimes when you decannulate, sometimes some sort of vasoplasia, or post-LVAD patient, these patients tend to be vasoplegic as well. And the vasoplasia shock, you can know that by patient being warm with a high cardiac index. So there are few golden rules for cath activation. If you are in doubt, activate the cath and then have the discussion and then start from there. If the TEE did not show tamponade or RV failure, that's a time to activate the cath lab as well. As we mentioned, rising lactate and ST elevation is always an important factor. So I'm going to give you a few cases and then we'll conclude. Post-cabbage shock. So you have a day 1 post-cabbage patients. You have a MAP of 55 in nor-epi, lactate of 4.5 and rising. And you have a new anterior ST elevations. And then you do a TEE and you find the new anterior wall hypokinesis. That's no-brainer. That's a time where you want to talk to your interventional colleague and activate the cath, because graft failure usually it's the reason until proven otherwise. Some critical numbers as red flags, usually lactate more than 4 and it's still rising despite optimization of all your therapies and IV fluids. Mixed venous less than 60 plus a hypotension and a new LV dysfunction. Let's say the patient went to the OR with an EF of 50% or 55%, and then they had some sort of hypotension, hypoperfusion, and you find the EF to be at 20% with some regionality. The wedge pressure more than 18, that's usually if you have a Swan-Ganz placed in with pulmonary edema, as we pointed, ST elevations and wall motion abnormalities as well. So cath versus TEE versus weight doing nothing. If the tamponade was suspected, then TEE. If RV failure, high CVP, clear lungs, RV support, do not cath. And we mentioned the other two. If the patient is stable but suspicious, you can start with echo in short periods and biomarker trends. I'm not sure about different hospitals, but in these patients and overall in cardiogenic patients, we developed a shock protocol where there is a shock code similar to the STEMI code, basically, where you have a patient who's deteriorating, you just call the bleep holder or the activation and you say activate cord shock. And the call will be placed to 5 operators, okay? The cardiovascular ICU, the cardiac surgeon, the interventional cardiology, the heart failure, and the primary cardiologist taking care of the patients. And all of these meet in a Zoom meeting within 5 minutes and discuss the case and then make a decision based on that. So in these patients, usually you don't have to deal with them alone. Calling a colleague or a different expertise is always valuable. So case 2, an RV failure, no cath, day 0, post tricuspid valve surgery, that's in the right side of the heart. You have a MAP of 60, but your CVP is 22 and your lungs are clear. That's a good sign that this is mainly a failing RV. And usually the lactate is not that bad, no ST changes. And then you do your echo, you find the answer. And at that time, you want to start your inhaled nitric oxide or some sort of RV support, either RP or Protec-2. Okay. Day 1, post AVR, lactate is rising, warm, high cardiac index, echo looks normal. Actually, sometimes it's hyperdynamic LV function. Always think vasoplegia first, not LV ischemia, and cath only if the echo showed some sort of LV function change. Late presentation or late day 3 in STEMI pattern. So day 4 post-cabbage, chest pain, troponin rising, and we're going to talk about what kind of troponin we're talking about, some sort of ST depressions, over stable hemodynamics. This we usually tend to control medically and then schedule a controlled cath instead of emergency cath. Because the activation for emergency, usually you skip some of the safety measures and you start loading the patients with heparin, Plavix, and aspirin, and then you rush the patient. But in these cases, you don't have to do that. You can actually follow for the next day if the patient are completely stable. So this is the protocol we developed locally at KFMC, specifically for post-cardiac surgery patients who we want to activate the cath lab. So the purpose was basically to standardize guidelines, our guidelines, for cath in patients who had recent cardiac surgery, just to ensure the safe evaluation and management post-op for these patients, either due to graft failure, ischemia, or any sort of instability. Most of the mechanical security supports, we put it in the cath lab, ECMO, Impella, all of them. So that's why activating cath lab for us means more than a left heart cath. The scope is this policy should be all post-operative cardiac surgery who require diagnostic or interventional cardiac procedures. The team, as I mentioned, cardiac surgery, cardiac ICU, interventional cardiologist, and we tend to involve heart failure team as well. The indication to activate the cath lab, this is our own protocol, ECG evidence of ongoing ischemia, unexplained hemodynamic instability associated with low cardiac output despite support, persistent arrhythmia, and that's usually a warning sign, unexplained cardiac arrest, especially if it's shockable rhythm, unexplained pulmonary edema, and worsened chest pain if the patient is awake. So you have to define the MI because, you know, post-ops, usually they're going to have a rise in troponin. So what is type 5 MI? And elevation in the troponin 10 times in a patient with normal baseline, or more than 20% in whom baseline was elevated but stable. This in conjunction with a new echo findings, especially new regional wall abnormalities, new pathological Q wave, ST elevations, or a new left bundle, and that's the onset in the first couple of days to 3 days. So this is the pathway we put for these patients. So the graft failure could be associated with unexplained hemodynamic instability, persistent arrhythmia, unexplained cardiac arrest, pulmonary edema, or worsened chest pain. Post-op ST elevation, if it's a yes, review previous ECGs. That's always helpful because maybe these patients have ST elevations either due to cardiac aneurysms or any sort of ST elevation they had in the past. If it's a new ST elevation or new left bundle with elevated troponin, if the answer is no, just continue serial ECG and hemodynamic monitoring. If the answer is yes, it's better to do a couple of ECGs to confirm the finding if you can do TEE, because this decision is not based on interventional side only. The surgeons care about their patients, care about their outcome, and they want to be part of the decision. So this pathway was consulted by interventional cardiology as well as the cardiac surgery, because the intensivists sometimes tend to send the patient to the cath lab while the cardiac surgeon would like not to. So this was in favor of everyone. And then if the persistent ST elevation plus new echo findings, if the answer is no, then you repeat the echo after 24 hours. If the answer is yes, we put here the shock team, which is the multidisciplinary decision. If it's stable hemodynamic, you wait for the decision. If it's not stable hemodynamic, you take the patient to the cath lab and either consider MCS or cath the patients for graft failure. That would be all the material you have in this topic. Again, it's more of a practical guideline to you, more than theoretical one, but I'm happy to receive any questions you might have.
Perfect. Let's take a look at the chat here. If anyone has questions for Dr. Mohammed, please post them in the chat or in the Q&A area so we can address them. But those were great, 4 very different cases. Until we get more questions in the webinar chat, I was just curious more of in this post-cardiac surgery patient population that's quite difficult, what are the challenges you anticipate in terms of access for diagnostic angiography? And what are the challenges that you normally come across in terms of managing these patients' anticoagulants before, during, and after, if the decision is made to do an angiogram?
Yeah, great, excellent. But when you say access, you mean access to the cath lab or an actual access in the patient?
Actual vascular access in the patient.
Actual vascular access. Okay.
After
So
the decision is made to proceed that way by the
yeah, yeah, you know, some of these patients have cannulations and sometimes all of their access are full, but we tend to go femorals most of the time in these patients, wherever femoral access is there. If the patient has a femoral one he's dependent on, we try to tend to switch it to if we want to put an ECMO or something like that, and then we utilize the line that they have before. Preferably, usually patients should have clean lines, but we tend to go to femorals more than radial. You know, the grafts, unfortunately, if there is a lima, the right radial would be an issue, and left radial, then you're going to have like maybe more time. That really depends on the stability of the patient and what time do we have. That's for number one. Number two, in terms of anticoagulation, if you are suspecting ischemia, unfortunately, you have to prioritize the thrombosis part more than the bleeding part, and you just have to use whatever you can. If you are doing diagnostic through femoral, then you spared yourself IV heparin. But if you ended up PCIing the patient, unfortunately, you have to pull the trigger and give the full blast of medications. Yeah.
Perfect. We have a question here by Mohammed Abdullah. How much rising troponin if it was valve surgery and CABG to consider significant?
Yeah, so as we pointed in the graph, that's if it's 10 times more, that's the type 5 MI, 10 times more if the level was normal in the past. If the level was elevated to begin with, increase in 20% would be considered significant.
Perfect. And I think this also highlights how important it is to have baseline troponins on the patients.
100%,
You can
100%.
compare, but that's a great question. We have a second question from Murad Mabrouki. Is there guidelines for post-operative cardiac surgery, cath lab?
So there is the MI guidelines, which address the post-cardiac surgery patients, but all of these guidelines, remember, guidelines meant to be cross-sectional, right? Across the globe for all the hospital, different levels. But depends on your some of the hospitals, they have access to ECMO and Impella, all these support. You should not have the same guidelines as someone who only have access to medications without any MCS. You know what I mean? So the guidelines, either Saudi guidelines, European, Canadian, American, these guidelines are meant to be cross-sectional. But if you are an advanced center, then you should have your own niche guidelines and own protocol based on the tools you do have. And that's something you should develop locally.
No
Hope
more
that
questions.
answered the question.
What was that? Sorry.
Hope that answered the question you.
Yeah, no, this is a very helpful discussion.
Yeah, then it means that everything was clear.
It is clear. There's one more thing I wanted to ask, since this is left heart catheterization,
Yeah.
post-cardiac surgery. So can LVEDP or coronary flow patterns in post-cardiac surgery caths reliably differentiate vasoplegia from true pump failure? Or does it not help clarify the picture between those two?
Honestly, when I want to decide about that, my guide is the right heart cath and the Swan. Like based on these numbers, I would make my decision. Like I would look at the SVR, I would look at the mixed venous, I would look at these numbers and then differentiate if it's this cardiogenic or more of a vasoplegia.
And oftentimes post-cardiac surgery, at least where I did my residency training in Cleveland Clinic in Ohio, they all almost had right heart catheterization in the monitoring period in the ICU. Is that common practice in your hospital or?
Yeah, so at Tufts, that was the case. Right heart cath, everyone get an IV line and a right heart cath. And but here, no, unfortunately, the practice is not the same. Right heart cath is usually goes to who's needed. I think people are still stuck with the data that was like 20 years ago, that right heart cath is not that helpful. I think the only reason it was not that helpful because we didn't know how to read it. But now we can read it, we can interpret the data, and utilizing these numbers are actually very valuable. To me, managing cardiogenic shock without a right heart cath is like driving in the highway with a high speed without any lights. You know, you have no idea what you're doing. You don't know how you tailor your diuretics. You don't know how you tailor your inotropes. You're really blind-sided by all of the factors. So it is a very important skill to have.
That's a great analogy. I completely agree. We don't have any more questions in the Q&A.
So we made it on time, 25 minutes. Excellent.
Oh, what? One more. I spoke too soon. From Abdel Munim Al Bahar, I think it's very difficult to assess the pain because of surgical wound and chest tubes.
100%.
Which, yeah, it highlights the difficult patient population that you're dealing with and the more supportive criteria that you need to make the decision that you have to do in order to triage the patient.
100%. I think this is very valid point. Most of these patients are usually sedated and intubated, so you have no idea. But even the awake one, like good luck differentiating the chest pain they're having, if it's related to MI or if it's related to wound pain. And these patients usually tend to be in a good dose of opioids. So you have no idea if the pain actually there or not. And that's why we put all of these criteria in the pathway you've seen to put everything together before pulling the trigger and taking the patient to the cath lab.
Absolutely. So we're right on time. Thank you so much for your time, Dr.
Just I
Mohammed.
have a question,
Yeah,
Dr. Bashar. Just for Dr. Muhammad, post-op RV failure is common, especially post-cardiac surgery. And I'm a bit concerned about when the time to rule out ischemia.
You
If
mean
we
like
have,
related to RCA that's causing RV
yeah,
failure?
yes.
Yeah, I think this is very valid point. Isolated RV failure usually tend to be affecting hemodynamics only, but if you are having an ischemia that consequently related to RV failure, then you should see something in the ECG. You will never have an RV failure without seeing something in the ECG or at least in your echo plus the troponin. So in order to cause RV failure because of ischemia, the ECG is not going to stay quiet.
Okay.
And again, I think I highlighted this before, but this is not a one-man show. You cannot make this decision because I rely a lot on my cardiovascular intensivist colleagues. I rely a lot on my imaging colleague. I rely a lot on my colleagues in the cardiac surgery and in heart failure as well, because these patients, risk is very high. We're not talking about only benefit. So we have to weigh both and make the decision that's best for the patient.
There's one more comment as well from Abdel Munim. Also, myocarditis and pericarditis is common post-cardiac surgery, was the comment.
Yeah, Dressler syndrome, that's for sure. Again, pointing that it's more of a puzzle you have to put together. If it fits related to ischemia, then you should pull the trigger. But if it does not, then it's better to find an alternative diagnosis.
Absolutely.
I think Dr. Ismail, he cannot attend. He has a central ECMO patient.
Okay.
To conclude.
If you would like, we can wait for 10 minutes to see if we can hear back from him because we might be able to squeeze it in. Otherwise, we can conclude the session. But thank you, Dr. Mohammed, for your time and for answering all those questions.
Thank you.
Thank you.
If you allow me, Dr. Mohammed, thank you for your informative.
By the way, Dr. Ahmed Al-Ghamdi is here with us. Dr. Ahmed Al-Ghamdi, he is the one who did that.
Thank you.
Thank you. So we owe him that.
I just wanted to get back to the troponin question.
Yeah.
Usually post cardiac surgery, there were a lot of manipulation with the cardiac tissue, suturing and troponin, and most of the time is going up more than 10 times. So do we have to rely on the troponin level, or we have to get back to something else?
Yeah. So as you know more than anyone else, that troponin can be misleading in a lot of these patients. But if it fits with the picture, then yeah, we can consider it. But as we pointed, even a baseline in the first couple of days post-op, it would be very helpful because troponin tend to peak and then goes down. But if it changes the direction, that's a sign that regardless of the level of the troponin should never go down and then go up again. It should head one direction. And if start going up again with some hemodynamic instabilities and any evidence in the echo, that is troponin we should care about. Even NMI patient, when we cath them, we do a troponin next day, maybe a little bit up, but then it start going down. But if the troponin goes up again after trending down, that's we always take it seriously. Hope that answered the question.
Yes, it's clear. Thank you. Thank you, Dr. Muhammad. Thank you, Dr. Shair.
Okay,
Great. Well,
you.
thanks for having me. All the best.
Perfect. Thank you. So yes, unfortunately, Dr. Ismail can't be here. He's caring for a very sick patient. So I apologize for the change in plans, but we'll conclude and hopefully we'll add it on as a recorded lecture in the future.
As we come to the end of the two-day session, I would like to take a moment to sincere thank for Dr. Muhammad Al-Mahmadi, also Dr. Bashair, for their excellent and insightful talk and discussion. A special thank to also who goes to our audience for taking their time to join us, for also thoughtful question and for ongoing interest in continuous medical education. We hope to find today's webinar informative and inspiring, that has been provided you with the valuable knowledge and you can apply in your daily practice. We will look forward to seeing you again in our upcoming webinar and educational program. See you soon, inshallah. Ma'assalam.